We have Ms. Blunt Rochester from Delaware. You're now recognized for 5 minutes for questions.
Thank you, Chairman Guthrie and Ranking Member Eshoo for the recognition, and thank you to our witnesses for your testimony. Today, we are considering healthcare provider policies, including my bipartisan bill, the Increasing Access to Quality Cardiac Rehabilitation Care Act, H.R. 2583. And I want to thank my colleague, Representative Adrian Smith, for his tireless work on this bill, and also acknowledge that he worked alongside our late colleague, John Lewis, on this bill, and I'm proud to be taking up the mantle. This bill will increase patient participation in cardiac and pulmonary rehabilitation programs, two life-saving services, by authorizing physician assistants, nurse practitioners, and clinical nurse specialists to order them. These interventions are proven to reduce mortality rates, hospitalizations, and costs. Unfortunately, they have historically been underutilized due in part to a lack of referrals from physicians and inadequate follow-up after referrals. Congress attempted to address this issue by authorizing certain additional providers to supervise cardiac and pulmonary rehabilitation in the Bipartisan Budget Act of 2018. However, CMS has indicated that while this policy change is an important step forward, they, quote, do not anticipate any significant increase in utilization of cardiac and pulmonary rehabilitation services and subsequent impact to the Medicare program. Dr. Shashamani, we all know that these programs reduce mortality rates and hospitalizations and costs, but can you describe why participation remains low in these programs despite the potential benefits?
I appreciate you raising this. We agree that cardiac and pulmonary rehabilitation are important and beneficial for Medicare beneficiaries. We looked at literature and studies on utilization rates for the impact analysis of the proposed changes that would implement what you referred to with the Bipartisan Budget Act of 2018 to allow PAs, NPs, and others to supervise these programs. And we will continue to monitor utilization of these programs after implementation of this new requirement and can continue to work with you on this issue.
Can you just describe how CMS concluded that allowing these groups to supervise these programs without the authority to put in orders may not increase participation? And what other potential solutions may increase access and utilization of cardiac and pulmonary rehab?
We used the literature and studies that were available on the utilization rates, and this points to the need to continue to examine the utilization when these changes are made, and we would be happy to continue working with you on this as we agree that cardiac and pulmonary rehabilitation is an important service for Medicare beneficiaries to have access to.
Yeah, I think what's important here is they need the authority as well. And so I want to switch to primary care for the minute and 30 seconds that I have left. Delaware, like other places, are experiencing a shortage in primary care providers, and that's why I'm one of the primary sponsors of the bipartisan effort to reauthorize the Community Health Center program, and why I serve as one of the co-chairs of the Primary Care Caucus. And Delaware, we've seen that while primary care physicians are accepting new patients, for Medicare and Medicaid, it's much lower, and this is a big concern. So, Dr. Macy, in your testimony, you described certain financial pressures healthcare providers face, including primary care providers, that may influence their decision to see Medicare patients. Can you please highlight a few of those?
Yes, thank you for your question. So every year we monitor access that beneficiaries have to healthcare services, including clinician services. This year we recommended an add-on payment to target additional resources to help support care. And a key thing I want to point out is that we structured that add-on payment so that it would be higher for primary care clinicians when they provide services to low-income Medicare patients. And we think that's an important way to target Medicare resources to shore up access.
Thank you. I'm going to submit questions for the record, but along that line of implementing G2211 and the add-on, We've heard that from some that it's not justified, not resource-based, it's costly and duplicative, and so and also leading to overpayment. So we'd like to follow up with you all on your answers regarding that as well. And thank you so much. I yield back.
Thank you. The gentlelady yields back.